So continuing on with the subtypes of schizophrenia, we were at the catatonic type, and I was just talking a little bit about catalepsy, which is the indefinitely prolonged maintenance of a fixed body posture. So you can, these people will keep the same posture for an extended amount of time, and it'll be kind of awkward positions that they'll maintain. Just be aware that catalepsy and cataplexy, they sound a lot alike, but they mean completely different things. Cataplexy is what you see in patients with narcolepsy, where a highly emotional event triggers this drop attack. So somebody tells a really funny joke, and all of a sudden the person's on the floor. That's cataplexy. So keep those things in mind because they might want to trick you with those. Then next is undifferentiated type. This type just has a mishmash of symptoms. It doesn't really fit into any type that great. And then the residual type is the absence of any active psychotic symptoms, and they don't meet criteria for the other types. Normally, these patients have just a lot of negative symptoms, apathy, withdrawal, that type of thing. So the duration of schizophrenia, just remember, the duration of the illness is for at least 6 months. This includes the prodrome, the active psychotic phase, and the residual phases. It might be better assessed in retrospect after a person starts having floridly psychotic symptoms, because you might look back over time and see, oh yeah, they were declining in functioning over the past few months. Their grades were getting worse. Oh yeah, they got fired from their job, and start putting the pieces together. But before you see the active psychotic symptoms, the prodrome phase looks a lot like depression or a lot of other different types of mental illnesses. So you won't know exactly what it is until they start showing the floridly psychotic symptoms. And these psychotic symptoms, this active phase, must be present for at least 1 month. All right. So you got the 3 phases, which I discussed: the prodromal, the active psychotic phase, and the residual. Okay. So epidemiology. Schizophrenia is present in 1% of the population worldwide. There's a higher incidence in the urban poor. This could be partially due to the downward drift theory, that once they start getting sick with schizophrenia, they start drifting down in socioeconomic class and eventually are poor because they can't keep a job and they're unemployed, and that's how they end up. Substance abuse, really highly comorbid with schizophrenia. Important to know, men and women are equally affected. This is unusual because for a lot of the mood disorders and a lot of other mental illness, women tend to be more affected. But for this one, it's men and women equally. And men tend to get this at an earlier age compared to women too. And men also have a lot worse prognosis compared to women. There's a large genetic component in schizophrenia, 50% concordance rate among monozygotic twins, large inheritance if both your parents have schizophrenia, and even if one of your first-degree relatives is infected, this increases your risk quite a bit too. Interesting, people born in early winter and spring seem to have a higher incidence of schizophrenia. Nobody really knows the reason at all. And there's also a fairly high suicide rate associated with schizophrenia. Usually occurs within the first few years after diagnosis. This is when they have the most insight into what's actually happening to them, and the severity of their prognosis kind of hits them strong. So the suicide rate is highest within those first few years. This is a graph showing males versus females, age of onset. You can see in red here, the females tend to have it a little bit later, but they have 2 spikes. They have one in their 20s when the men seem to get it. Then they also have a little bump here in their mid-30s. And so it averages out that their average age of onset for females is about 29 to 30, where in males it's in their early 20s. Prognosis for schizophrenia, generally pretty poor. 50 to 70% of patients remain significantly impaired after they're diagnosed. Remember, there's good prognostic factors and there's bad prognostic factors. These are important. The good prognostic factors, if you get it later in age, if you have a good social support network, the more positive symptoms, the more mood symptoms you have, it's always good. The quicker it comes on, the better. Female gender protects you. Fewer number of relapses is great. Good functioning prior to onset, and an initial good response to medication. These are all good prognostic factors. I like to think that the later the onset, it's probably better prognostically because they've already gone through school, or they're already all set in their job, they've learned something. They're better educated, and they probably have a better social support system in place if they get it at a later age as opposed to an earlier age, which is probably why it's considered a good prognostic factor. The other thing with the positive symptoms and the mood symptoms, some people don't really understand why extra mood symptoms would be a positive thing, but I like to think it gives the patient some spark to them, something that makes them seem a little more engaging to other people, to make them easier to talk to keep that social support in place, to keep their family actively engaged. I think that's probably the reason why they have better prognosis. The poor prognostic factors are earlier onset, poor social support, negative symptoms. This refers to like the apathy, the social withdrawal, that type of thing. Family history, a gradual, slow course of onset, male gender, large number of relapses, and the worse they were functioning before their onset, this is just going to go downhill. So obviously this is a poor prognostic factor. Negative symptoms tend to worsen over time, so as they get older, they tend to have more of this apathy present and this flattened affect. There is an elevated rate of violence, but this is mostly when they're actively paranoid, actively psychotic, and the more disorganized they are, the higher their likelihood is of violence. Here's a graph just displaying that the more relapses a patient has over time, the worse their overall functioning is going to be. So on the vertical axis, you have functioning, and horizontal is time. And you can see the blue line, this is just the dips in their functioning with the relapses. So each time they get a relapse, they do get better with the medications and the treatment, but they never quite return to the level of functioning they were at before. So there's a step down decline. And this is why being compliant with their medications is just so important to preventing that overall decline in functioning. There's a bunch of theories about how schizophrenia came about. Nobody really knows for sure. The dopamine hypothesis is probably the most popular one because our antipsychotic medications that block dopamine work for psychotic symptoms. And dopamine agonists, like amphetamine, they tend to exacerbate psychotic symptoms. We think that this has a lot to do with the dopamine and the mesolimbic dopamine pathway of the brain. But there's a lot of other neurotransmitters that are probably involved, like serotonin, norepinephrine, things like that. And there's also clear structural brain abnormalities, like reduced volume in the prefrontal cortex, thalamus, hippocampus, increased volume of the ventricles, and fMRI studies have shown decreased blood flow in the frontal lobes as well. So there's a lot going on. Nobody really knows the exact cause. Here's a picture of a patient's brain with schizophrenia here, and you can see the enlarged ventricles versus a normal patient who does not have schizophrenia. You can see this person's also lost quite a bit of brain mass up here. You can see the atrophy that's going on. This is a PET scan. You can see a normal patient on the right with normal blood flow in the frontal lobes, and a schizophrenic patient on the right side here with decreased blood flow to the frontal cortex and the increased ventricle size too, you can see. So what's the treatment? We'll go over this in another lecture, but it's mainly antipsychotics, typical and atypical antipsychotics. Behavioral therapy is really focused on just educating the patient, educating the family. You want to try and help them with coping skills, interpersonal relationships, things like that. A group therapy session or a program is good because they can learn to meet new people, friends, work on their interpersonal skills. Then there's something called the ACT team, which goes out into the community. They actually meet the patient at their house, give them their medications. It's great for people that are non-compliant with showing up to appointments.